بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, in this topic we will handle one of the important issues in the imaging of the musculoskeletal system, which is the hematological bone diseases. And this topic is a little bit long, so I divided it into two parts, and we will handle these topics in both parts: the vascular necrosis, hemochromatosis, sickle cell disease, thalassemia, hemophilia, hereditary spherocytosis, and hematologic malignancies. Of course, the vascular necrosis is one of the most common hematologic problems affecting the musculoskeletal system, and there are a lot of changes all over the body belonging to the vascular necrosis. Then we'll deal with hematologic malignancies, which include lymphoma, leukemia, and multiple myeloma. Then, first of all, we would like to talk about the vascular necrosis, which is the most common hematologic condition affecting the skeleton. And by avascular necrosis, we mean that the blood supply is interrupted to a certain bone, and this will result in ischemia and death. And there are a lot of causes that contribute to avascular necrosis, and these include external vessel compression, thromboembolic disorders, and vessel wall disease. Vessel compression can be the sequelae of trauma or surgery, or idiopathic or regional infection, or neuropathic joint, Gaucher disease, hyperlipidemia. Veno-occlusive or thromboembolic disorders, as in arteriosclerosis, steroids, and alcoholism, thromboembolic syndrome, diabetes, trauma, and sickle cell disease. Vessel wall abnormalities, like in systemic lupus, polyarthritis nodosa, giant cell arthritis, and radiation therapy. These are the most common causes of vascular necrosis in children. One of the common causes is idiopathic and trauma and infection. Then in adults, the drugs, especially the steroids, alcohol, and the immunosuppressive drugs. Also, the trauma is one of the contributing causes, inflammatory arthritis, and the metabolic conditions like diabetes and Cushing syndrome and the pregnancy. And here I selected some of the topics that will be explained in this part of the lecture, and I tried that I will not, as much as I can, repeat the diseases that have been mentioned in other topics in the musculoskeletal imaging, but actually I wanted also that this topic to be comprehensive and including all aspects of the disease, um, even with a little mentioning about some of them. Then these are the locations that we would like to talk about: the metatarsal head, Freiberg disease, navicular bone, coiler disease, the talus, the patella, Sending-Larsen-Johansson syndrome, femoral condyle, osteochondritis dissecans, medial femoral condyle, a spontaneous osteonecrosis of the knee or sunk, femoral head, leg calvi-Bursus disease, phalangeal head, Thiemann disease, metacarpal head, uh, Mauclair or Dietrich disease, carpal leonate, Kienbock disease, carpal scaphoid, Brizier disease, humeral capitulum Banner disease, humeral head Haas disease, and vertebral body Kummel disease. And starting first by the Freiberg that I have mentioned before, which is the osteonecrosis of the head of the metatarsal bone, and it usually affects the head of the second and maybe also the third metatarsal bones. Sometimes it can be bilateral in about 10% of the cases, and usually affects girls in the adolescent period of age. And I think that one of the most common causes for this disease is this high heel. Then the patient will present by pain on weight bearing with swelling and tenderness at the affected metatarsal head. If you have the plain X-ray, many times you cannot see a disease, especially in early stages of the disease. But whenever you have MRI, you can detect some bone marrow edema corresponding to the head of the metatarsal bone. Then after that, if you have the plain X-ray, then you are going to see the full-blown picture of avascular necrosis, which are the collapse, the sclerosis, irregularity, fragmentations, all of the manifestations of the disease can be seen in this metatarsal head. And sometimes you got widening of the metatarsophalangeal joint, then you got osteochondral fragment, sclerosis, and cortical thickening. The second is the Coiler disease, which is a vascular necrosis of the navicular bone, and this is a self-limiting disorder, meaning that it can heal spontaneously. And this results from temporary disruption of the blood supply of the navicular bone. It can be idiopathic or secondary to trauma. The age incidence is between 3 and 10 years of age, and is commonly unilateral but can be bilateral in about 25% of the cases. There is some swelling and pain at the site of the navicular bone. On X-ray, you will see some flattening, fragmentation, and sclerosis of the affected navicular bone as compared to the normal one. And regarding the talus, you know that we have 4 stages or 4 grades of avascular necrosis of the talus. Grade 1 is just bone marrow edema, and this is only detected by MRI. And you see the talus is edematous and of low signal in the T1 and high signal in the T2 weighted image. Of course, there are a list of differential diagnoses for Taylor edema, including the edema secondary to trauma and inflammatory bone marrow edema and the avascular necrosis and also the reflex sympathetic dystrophy syndrome. And this is stage 1, avascular necrosis. Stage 2 is the separation of the necrotic bone, which will have the signal of fluid, low signal in the T1 and high signal in the T2. And stage 3 is the separation of the necrotic bone without displacement. And you got this appearance, and you say the separated necrotic bone but it is still in its location. And this is the CT scan of another case, and you see the separated necrotic sclerotic bone with sclerosis of the edge of the donor bone. Then the stage 4, the separated bone fragment will leave its site, and you got an empty depression or an empty notch at the site of the necrotic bone, and this may be filled by fluid, as you can see on MRI. Then Sending Larson-Johansson syndrome is a chronic traction injury of the immature osteotendinous junction of the distal end, actually, of the the proximal end of the patellar tendon, and this may be associated with bone marrow edema and abnormal configuration of the lower patellar ball. And I have mentioned before the changes in the jumper's knee, where you got tendinitis or tendinosis of the patellar tendon associated with some bone marrow edema of the lower ball of the patella. And this is another example. It is known as Sending Larson-Johansson syndrome, where you got abnormal signal in the proximal edge of the on the proximal end of the patellar tendon, and this may be associated with bone marrow edema of the distal patellar ball, as well as some abnormal configuration of the distal patellar ball. Now, Lehmann disease is a non-inflammatory disorder of unknown etiology. It is a familial, inherited as autosomal dominant disease, and it is an osteochondrosis of the epiphyses of the phalanges. And the disease involves the proximal interphalangeal and the distal interphalangeal joints, and most of the cases are seen in children and young adults before the age of 25 years. The most commonly affected phalanges are the second and the third. The phalanges of the second and third fingers, and the disease is initially painless, but later on there may be pain and deformity with irregularity of the epiphyses, and after that there is sclerosis and broadening as well as fragmentation, all the criteria of a vascular necrosis. Sometimes they call these epiphyses the ivory epiphyses. Then if you look here, and you can see, sorry for the haziness of the image, but you may be able to see the changes at the phalangeal end and of the second, and then the third, maybe the fourth and fifth finger as well. And this is a well-known criteria of the disease, is commonly affecting the second and third, but may also affect the rest of the fingers. And this is what I mean by the ivory epiphyses. And here you got one of the well-known criteria of osteonecrosis is the increased bone density and the fragmentation. And here you can see the classic appearance. Then we came to the Mauclair disease or Dietrich disease, where there is osteonecrosis of the metacarpal head, and this also occur at the second and the third metacarpal heads. And the previous disease, Lehmann disease, affects the phalanges of the second and third, and this disease affects the metacarpals of the second and third. And the age incidence is between 13 and 18 years old, and you know the contributing factors, which may be spontaneous or trauma or steroid abuse or steroid use on systemic lupus erythematosus. Then all the criteria of a vascular necrosis are seen in the metacarpal head in the form of flattening of the head, widening of the joint space, deformity, and osteoarthritis with narrowing of the joint space. Then you got osteochondral fragment, periosteal reaction, and the metaphyseal cortical thickening, almost similar to the changes of the Freiberg disease in the head of the second metatarsal bone. And this disease, Moncler or Dietrich disease, affects the head of the third and the second, maybe the second and the third heads of the metacarpal bones, showing the abnormalities of avascular necrosis in the form of flattening, irregularity, bone sclerosis, and fragmentation. Another example of the third metacarpal head, showing the classic criteria where you can see the irregularity and the fragmentation. Of course, if you are reporting these x-rays without a good clinical background, you are going to miss a lot of lesions. And I think if you do not have a specific um, complaint referring to this particular area in the hand, you will write it as a normal radiograph. Then this is one of the possible ways for treatment of such a disease, is to put what looks like a prosthesis to maintain the function of the joint. Then the Banner disease is an osteochondritis of the capitulum. But also, we have an osteochondritis dissecans of the capitulum, and there are some differences between Banner disease and osteochondritis. Banner disease affects the whole capitulum, but the osteochondritis affects part of the capitulum. Banner disease occurs at a relatively younger age compared to the age of osteochondritis dissecans. Banner disease do not result in an intra-articular loose bodies, while osteochondritis dissecans, whenever the bone fragment is displaced, it will result in loose body inside the joint. And Banner disease is an osteonecrosis of the whole capitulum in a relatively younger age, and it does not lead to the formation of loose bodies in the elbow joint. And this is another example, and you see the sclerotic texture, the collapse and the fragmentation of the capitulum by MRI. The Embrisier disease is the avascular necrosis of the scaphoid bone, which is not fractured, meaning that this is an idiopathic vascular necrosis of the scaphoid bone, which affects the whole scaphoid bone. And this is known as Embrisier disease. And the manifestation of is avascular necrosis, which are in the form of increase in the bone density and fragmentation. And you remember the nipple sign, which means that the proximal bone of the scaphoid bone is pointing more pointing than usual, and this is known as the nipple sign, which is considered one of the signs of vascular necrosis of the scaphoid bone. But actually, if you see that scaphoid with this dense sclerotic texture, you do not need other signs to reach the diagnosis. Then a vascular necrosis of the humeral head, which is known as Haas disease, and is considered the second most common site for osteonecrosis after the hip joint. And one of the underlying causes is the corticosteroid use, and it affects the subchondral area of the humeral head with all manifestations of avascular necrosis in the form of collapse, fragmentation, sclerosis, and irregularity of the articular surface. By MRI, you remember the classic appearance of avascular necrosis in the femoral head and also anywhere in the body where you got a line that separates the dead bone from the healthy bone. And this line is considered one of the most important diagnostic signs for the avascular necrosis. And depending on the signal intensity of the bone bordered by the line, the dead bone, there are staging of the avascular necrosis as I have mentioned before. And this is another example of avascular necrosis of the humeral head with the classic line separating the dead bone from the viable bone. Then Kumel disease is vascular necrosis of the vertebral body. And there is usually some, or there may be a history of trauma. Then you got some fracture of the vertebral body, and after that you got collapse and the development of intravertebral air, which is known as the vacuum cleft. And this vacuum cleft is considered the diagnostic sign of a vascular necrosis of the vertebral body. There are some of the risk factors for development of avascular necrosis, including osteoporosis, corticosteroids, alcohol, and radiation therapy. The lesion will appear of low signal in the T1 and increased signal in the T2 weighted image, and you may be able to detect air, but usually air is detected more better by the CT scan. Then osteochondritis dissecans is an osteonecrosis of unknown etiology, affects the lateral aspect of the medial femoral condyle in about 75% of the cases. And this will result in a necrotic bone fragment that will be separated from the condyle and may be displaced as a loose body inside the joint. And this is an example. You see an osteochondral fragment of the medial femoral condyle, which is not yet displaced from its side. And this is the grading or the classification of osteochondritis dissecans. And then in the stage 1, you got bone ischemic changes with no separated fragments. And in stage 2, you got partially separated osteochondral fragment. In stage 3, you got totally separated but not displaced bone fragment. And in stage 4, you got displacement of the separated osteochondral fragment. Then these are some criteria mentioned by the literature about the fragment, whether it is stable or not. And these are the criteria which are in favor of unstable fragment. If the fragment is larger than 1 centimeter, if there is fluid at the base of the fragment, if there are cystic changes at the donor aspect of the defect, and if you inject contrast material and you got enhancement of the separation line, this may indicate that this fragment is unstable and it has the chance to be displaced as a loose body in the knee. Then you got to the medullary bone infarction, and this may be seen in the metaphysis or in the diaphysis, and it may also affect the epiphysis, but at that time it is called a vascular necrosis, and I will mention something about the epiphyseal avascular necrosis just in few minutes. Then bone infarctions will tend to have a well circumscribed sclerotic margin, and the infarction is not usually associated by perosteal reaction or thickening of the cortical bone or expansion of the affected bone. Then you got multiple or single irregular shaped intramedullary lesion with which is well defined, and it may have the double cortical or double contour line, and sometimes if it is solitary it may be mistaken for an enchondroma. But in chondroma, because of the chondroid matrix, and you got internal calcific shadows within the lesion. In chondromas are not usually multiple, and according to the literature, it is usually unnecessary to discriminate between both, since they are the infarction and the enchondroma, they are benign lesions. And this is the classic appearance of bone infarction by plain X-ray in the femur, in the tibia, in the proximal femur on the right side. And this is the appearance by the MRI, where you got this appearance of a well-defined line. You remember that this have been described in the literature as the Chinese figures. And you got in the T2 weighted image the double line, a black line from inside and the bright line from outside. Then the intramedullary calcification, as you can see here, may be seen in the bone after months or years, but the MRI can detect bone infarction within 6 to 12 hours of its occurrence. And the central signal of a chronic infarction is almost similar to the normal marrow, the central part, and is separated by the line. This is the ischemic bone, and this is the viable bone. And the double line sign is considered one of the classic features of a bone infarction, which is not present in metastasis, lymphoma, or leukemia. Then this is the classic appearance of a bone infarction in the femur, and another one in the tibia, in the frontal view and in the lateral view. This is the appearance of an infarction by MRI T1 weighted image and the T2 weighted image, and is easy for you to detect the double line sign. And this is also an infarction, multiple intramedullary infarctions in the femur and tibia, and you got the spontaneous osteonecrosis of the medial femoral condyle with bone marrow edema and flattening of the femoral condyle as well. Then we came to the Blount disease, which is a disease resulting from gross disturbance in the proximal part of the tibia. And it affects the medial part of the epiphyseal plate, the epiphysis and the metaphysis. This is the epiphysis, and this is the physis or the epiphyseal plate, and this is the metaphysis. And we have two types. The infantile type, which is more common, occurs under the age of 3 years, and the juvenile type, which can be seen up to 11 years and older. And the infantile type is usually bilateral in about 80% of the cases, while the adolescent type is unilateral in about 80% of the cases. Then if you see these criteria where you got some fragmentation and maybe sclerosis of the medial part of the tibial epiphysis, flattening of the metaphyseal end, and this metaphyseal peak which is considered one of the characteristic criteria of blount disease. And the changes on the medial aspect would result in deviation of the leg medially and consequently a varus deformity. And then yeah, you may sometimes, according to the literature, you can measure the angle of the varus deformity by number one, having a line through the long axis of the tibia. Then you draw a perpendicular line to this axis of the tibia. Then you draw a line along the affected part of the metaphysis of the tibia, and you measure the angle between these two lines, and an angle more than 11 degrees is considered abnormal. And Blount's disease by time will progress into more avascular necrosis and more varus deformity of the knee joints. These radiographs are obtained at the age of 3 years, and the follow-up 2 years later showed the more progression of the disease. And this is another example, and you see radiographs obtained at the age of 15 months and at the age of 6 years, and this after surgery, which has been performed at the age of 3 years to correct the deformity. This is the adolescent type of Blount's disease. You got a small size of the epiphysis compared to the lateral aspect, and you got some irregularity of the physis, and in the X-ray you may see the sclerotic changes. Then we came to the Sherman disease, and the Sherman disease is also known as juvenile kyphosis or juvenile discogenic disease or vertebral epiphysitis. We have two types of Sherman disease. The typical one, which involves the dorsal vertebrae seen in adolescents, and the atypical one, which involves the dorsolumbar or lumbar spine and seen in adults. From its name, adolescent kyphosis or juvenile kyphosis, the main presentation is by kyphotic deformity. And this kyphotic deformity is secondary to degeneration and septic necrosis of the vertebral end plates, resulting in narrowing of the disc spaces and the resultant kyphotic deformity. This disease is seen in about 5% of the general population with a slight male predominance. The etiology is exactly unknown, and there is a strong hereditary predisposition. The common segment of the spine to be affected is the dorsal spine. And these are the Sorensen criteria of classic Sherman disease. Number one, the thoracic spine kyphosis. The kyphotic angle is more than 40 degrees. I will show how to measure the kyphotic angle. The kyphotic angle, the normal angle is between 25 and 40. Then the thoracolumbar spine kyphosis, more than 30 degrees. Normally, it is in the range of 0 degrees. At least 3 adjacent vertebrae demonstrate wedging of more than 5 degrees. And if you look here, and you can see some anterior wedging of the vertebrae, marked narrowing of the disc spaces, multiple humeral nodes. And they taught us that one of the of the major diagnostic criteria of Sherman disease is the presence of humeral nodes. Then you got vertebral end plate irregularity with extensive disc invagination or humeral node, intervertebral disc narrowing, which is more anteriorly, and this will contribute to the kyphosis, apophyseal joint separation, and there are some associations, which mainly the femoral nodes, limbus vertebra, which is the non-union of the ossification center of the upper vertebral end plate at single or multiple levels, scoliosis, and spondylolisthesis. And this is the way how to measure the kyphotic angle. And you see the kyphotic curve, and you select the upper vertebra where the curve is starting to be corrected, and also you do so in the lower vertebra. Then you draw a line from the superior end blade from the upper vertebra and the inferior end blade from the lower vertebra, and you measure the angle in between. Sometimes these two lines will not meet. Then you draw a perpendicular line here and there, and you measure the angle as I will show it to you. Then there are some associations like anterior wedging of the vertebral bodies, disc space reduction, end blade irregularity, posterior disc bulge, disc dehydration, and herniation. And this is what I meant. If you draw a line, this is a wide kyphotic curve. If you draw a line like this and another one like this, they may not meet except outside the slide, for example. Then you draw a perpendicular line to this one and another perpendicular line, then you measure the angle between these two lines. This is known as the kyphotic angle. Osgood-Schlatter disease is a vascular necrosis of the anterior tibial tuberosity and is seen in adolescent in the age between 10 and 15 years, and the condition is bilateral in about 50% of the cases, and the etiology or the suspected underlying etiology is the repetitive trauma with traction on the patellar tendon, which is often seen in jumping sports, volleyball, basketball, and gymnastics. The patient may present by intermittent pain at the tibial tuberosity and is worsened by exercise. There may be some edema, redness, and tenderness at the tibial tuberosity. If the tibial tuberosity is not ossified, then the X-rays will be of no help. Then radiographs obtained to exclude other causes of pain, like fractures and so on. If the tibial tuberosity is not calcified, and this is the age incidence where the tibial tuberosity is calcified, 9 years in girls and 11 years in boys, then you look for the lateral X-ray, and you got all the manifestations of a vascular necrosis, including fragmentation, irregularity, increased bone density, and so on. Then there may be some soft tissue swelling and calcification of the patellar tendon or thickening of the patellar tendon. By MRI, there are some of the diagnostic helpful criteria, even if there is no fragmentation of the tibial tuberosity. These criteria are three. Number one, increased signal intensity of the patellar tendon at its attachment to the tibial tuberosity. Number two, fluid signal between the patellar tendon and the tibial tuberosity and the tibial epiphysis. Then bone marrow edema of the localized bone marrow edema of the tibial epiphysis. And this is a classic appearance of Osgood-Schlatter disease with fragmentation of the tibial tuberosity, thickening and abnormal signal of the patellar tendon, fluid signal between the tendon and the tibial tuberosity, and also you got some bone marrow edema in the tibial epiphysis. Then we came to the Burset disease, which affects the proximal capital femoral epiphysis in children, and the underlying causes are almost similar to the causes of the rest of avascular necrosis, including trauma, infection, endocrine abnormalities, and so on. And this is common in boys in the age between 3 and 5 years. The classic appearance of avascular necrosis is the fragmentation, collapse, and the irregularity of the affected femoral epiphysis. And if untreated, you got osteoarthritis of the hip joint. And the treatment is usually by the avoidance of weight bearing, and there may be surgical options for this disease. The disease is bilateral in about 15% of the patients. MRI and bone scans are more sensitive in early stages of the disease to see the disturbance of the bone marrow signal in the affected epiphysis. Then there are a lot of signs for vascular necrosis of the capital femoral epiphysis, and these include beside the fragmentation, collapse, and the irregularity of the capital femoral epiphysis, there may be capsular distension due to joint effusion, a small fragmented epiphysis, or osteosclerosis, which is known as a snow cab sign, subchondral collapse, which is known as the crescent sign, a radiolucent defect at the lateral margin of the involved epiphysis, known as the cage sign, and curved radiodense cortical line at the base of the femoral neck. This is known as the sagging rope sign, which represents the margin of the deformed femoral head. Then gross deformity with wide short femoral neck and enlarged femoral head. This is known as coxa magna, and the flattened epiphysis is known as coxa plana. The femoral head deformity is known as the mushroom deformity. And this is the coxa magna, where you got flattening, broadening, and shortening, flattening and the broadening of the femoral head, shortening of the femoral neck. This is known as the head at risk sign, and in this sign you got progressive restriction of the hip movement, and there is widening of the inferior medial joint space, widening of the inferior medial joint space with flattening of the cartilaginous head and metaphyseal involvement. The gag sign is a lucent area on the lateral epiphysis in this particular area, adjacent to the metaphysis, and the horizontal appearance of the gross plate reflecting a clinical flexion abduction posture of the head. This sign is considered by the literature that there should be some way to prevent the progression of the disease. But you know that with conservative management, there may be complete healing of this avascular necrosis, and you see the sequelae. This is the start of the disease, more progression and fragmentation, then the start of healing. By this, we may finish the issue of avascular necrosis, and we can pass to the second item, which is the hemochromatosis. Hemochromatosis means that there is excessive iron storage and the deposition of hemosiderin into the tissues, causing tissue damage and dysfunction. The increased iron absorption may be either primary or secondary. The primary type is known as hereditary hemochromatosis, which is more common in males than in females. And the symptoms are seen between the age of 30 to 50 years. And the diagnosis is usually precedes the symptoms by the range of 10 years. The deposition of iron will lead to symptoms of arthralgia, and this will affect the second and the third metacarpophalangeal joints. And you got fatigue, apathy, lethargy, weight loss, loss of libido, and maybe impotence. And the finding on the plain X-ray will show progressive arthritis. Also, you may got liver cirrhosis by ultrasound or CT, sometimes a hepatocellular carcinoma, or in skin pigmentation. Then secondary, the hemochromatosis occurs because humans do not have a mechanism to increase iron excretion, which will allow iron overload. If the disorder occurs without tissue damage, it is called hemosiderosis. If it is associated with tissue damage, it is called hemochromatosis. And the severity of tissue damage is less in secondary causes. The secondary causes include increased iron availability in iron-loading anemias like thalassemia major and others. Parenteral iron overload, like in cases of iron blood transfusion, iron dextran injections, and hemodialysis. Chronic liver disease, as in hepatitis B and C, and alcoholic liver disease. Then the availability of irons in the blood may be the secondary of hemolysis due to anemia, the secondary of parenteral iron intake, like in blood transfusion, and some diseases affecting the liver. The X-ray will of patients with hemochromatosis should include the hands, the knees, the hips, the pelvis, and the spine. In the hand, you have the main features, which is affection of the metacarpophalangeal and maybe the proximal interphalangeal joints. The joints are affected by cysts and erosions, and commonly the second and the third metacarpal or metacarpophalangeal joints are affected with this classic appearance, which is known as beak-like osteophyte projecting from the medial end of the metacarpal bone. Then in some cases, you may got affection of the rest of the metacarpal heads. And cysts and erosions may may lead to symmetrical loss of the joint space, and this disease is closely associated with calcium pyrophosphate, calcium phosphate dehydrated disease. You remember, it's known as the hemochromatosis is one of this particular disease. Then chondrocalcinosis is also one of the manifestations, especially in the knee and the triangular fibro cartilage, and also osteoporosis may be seen in this disease. And this is the disease I would like to remember its name: calcium dihydrate pyrophosphate deposition disease, where you got deposition of calcium in the cartilage, and chondrocalcinosis is one of the hemochromatosis is one of the causes of this disease, including also pseudogout, hyperpara, osteoarthritis, ochronosis, gout, hemochromatosis, Wilson disease, acromegaly, and hypophosphatemia. Then the clinical picture of a patient with hemochromatosis include hepatomegaly, chronic liver disease, testicular atrophy, gynecomastia, loss of hair, skin pigmentation. This is the normal hand, and this is the hand of a patient with hemochromatosis, congestive heart failure. And this is a wrist X-ray showing the classic appearance of calcification of the triangular fibrocartilage. I mentioned that the changes are in the second and third metacarpopharyngeal joints, and also in the cartilage, especially of the knee and the wrist. Then, in order to remember the distribution of joint affection in the hands, considering these particular lesions, this is the joints affected by osteoarthritis, the proximal and distal interpharyngeal joints. In cases of rheumatoid, the metacarpopharyngeal and the proximal interpharyngeal. In cases of calcium pyrophosphate dihydrate disease, then you got affection of the metacarpopharyngeal joint. In cases of psoriasis, you know that it has a predilection to the distal interphalangeal joints. These are the diseases which can be included in the differential diagnosis of hemochromatosis. Then this is the appearance, as I have mentioned before. You got abnormalities in the second and third metacarpopharyngeal joints with this characteristic beak-like projection from the radial aspect of the head of the metacarpal bone. Another example of hemochromatosis in the hand showing the affection of the metacarpopharyngeal joints of almost all fingers with the, let us say, metacarpal hooks. And this is the classic appearance. Of course, you may remember that these metacarpal hooks are one of the criteria of acromegaly. But in cases of acromegaly, you got enlargement of the hand and feet and the widening of the metacarpopharyngeal joints, not narrowing of the metacarpopharyngeal joints. And this is another example where you got degenerative changes in the metacarpopharyngeal joints with the classic appearance of the beak-like projection from the metacarpal heads. Actually, when hemochromatosis affects the large joints, it cannot be discriminated from osteoarthritis. Then all what you can say here that there is marked narrowing of the joint space and there is subarticular bone sclerosis and osteophytic clipping as you can see here. But in order to differentiate hemochromatosis from osteoarthritis, you consider that hemochromatosis occurs at a younger age. And if you have the radiographs of the hand and you can see the characteristic hook like osteophytes in the metacarpopharyngeal joints, this will help you to spot the diagnosis. Since you remember that osteoarthritis of the hand will affect the distal and the proximal interphalangeal joints, it will not affect the metacarpopharyngeal joints. Then one of the manifestations also is to got extensive degenerative changes in the spine with calcification of the discs and multiple disc space narrowing. Together with this characteristic appearance of the hooks and the metacarpals as well as degenerative changes, then you know that you are dealing with hemochromatosis. And the differential diagnosis will include ochronosis, of course, because ochronosis is one of the diseases that affect the spine and results in very early changes in the spine in the form of marked degenerative changes, as you can see here. Then we came to the sickle cell disease, which is an autosomal recessive disease resulting in abnormal formation of hemoglobin, and this disease will affect many of the systems and organs in the body. There is a combination. The sickle cells are abnormal red cells, and they are liable to accumulate, forming thrombi to occlude the vessels, resulting in ischemia and infarction, and they are easily damaged, resulting in hemolytic anemia. This disease is of high incidence in Africans and Eastern Mediterranean inhabitants. The manifestations are usually seen in childhood because infants are usually protected by the elevated levels of fetal hemoglobin in the first 6 months. The presentation may be completely asymptomatic to severe crisis. And these are the clinical appearance. And the clinical appearance actually is the combination of these three issues: the vaso-occlusive disease or crisis, the chronic anemia, and the infection. Infection in the sickle cell disease is because of the damage of the spleen. And you know that one of the manifestations of sickle cell disease is autosplenectomy. And by time the spleen is almost lost, and it became very small and calcified. And that's why the infection is a well-known part of this disease. Then vascular occlusion, hemolysis, meaning that you got anemia and you got infection. Then in the bone you got bone pain due to infarction and subperiosteal hemorrhage and the infection. In the lung, and you got recurrent pneumonias and maybe the chronic lung disease. In the abdomen, you got pain and the sequestration syndromes, especially in the spleen, when a large amount of blood is trapped within the spleen, resulting in its rupture. In the kidney, renal manifestations, which may end by renal failure. In the brain, you may got cerebrovascular stroke and retinal artery thrombosis. In hemolytic anemia, will result in extramedullary hematopoiesis and marrow hyperplasia, impaired immunity due to autosplenectomy, and priapism and leg ulcers. Then, as I have mentioned, the appearance of sickle cell disease, and this name is referred to sickle cell anemia, will be the combination of ischemia, anemia, and infection. And bone infarctions will involve the medullary cavity and the epiphyses, the proximal humerus and femora, as well as the vertebral bodies are the most affected, with one of the classic features of sickle cell disease, which is known as the H-shaped vertebra. And this is how the H-shaped vertebra is uh, happens. And you can see this is the blood supply in the back and in the front of the vertebra, which is a little bit rich compared to the central part of the vertebra. Then in this disease you got the ischemic changes in the central part, which will collapse compared to the peripheral parts, and this will result in the H-shaped vertebra, which is considered one of the manifestations of ischemic changes in the vertebra. Then you may got perosteal reaction, and you got soft tissue swelling of the metacarpals and metatarsals, and the changes of the ischemic changes are difficult to be distinguished from the osteomyelitis. you got gross disturbance, chronic anemia, and marrow hyperplasia. Marrow hyperplasia is due to the expansion of the medullary cavity, and this will appear as increased medullary trabeculation in the skull. It will result in the classic appearance of hair on end appearance, and this change will be seen in any kind of anemias that may result in excessive need for the hemoglobin. Then osteopenia and pathologic fractures, extramedullary hematopoiesis, and red marrow conversion. You know that the bone marrow at the beginning of life is red. Then by time it is transformed into yellow marrow, and if there is a need for this marrow once again, then the yellow marrow will be reconverted into red marrow, especially in these particular cases. And this is a classic appearance of what is known as hair on end appearance. There is expansion of the diploic bone, and there is a striation between the diploi. And also you notice that the occipital bone is not involved because of the absence of diploic space in the occipital bone. And this is the classic appearance of hair on end. It changes. Sometimes you got some osteolytic lesions which are indistinguishable from those of myeloma. But in this particular patient, there is no evidence of myeloma. And you remember, in sickle cell disease, you may got this appearance, though rare, but you should consider it in the in the differential diagnosis. And this is a hand of a patient with sickle cell anemia or sickle cell disease. In this case, you got sclerotic changes with expansion of the metacarpal, periosteal reaction, osteolytic lesions surrounded by bone sclerosis. Then you know that the changes are the combination of ischemia, anemia, and infection. Anemia will result in expansion of the medullary cavity, and ischemia will have these appearances. Infection will have these appearances. Then, as I have mentioned before, and is also mentioned in the literature, sometimes it is difficult to differentiate between ischemic changes and inflammatory or infectious changes in the bone in patients with sickle cell disease. Also, some of the manifestations of sickle cell disease, like you see here, shortening of the fourth metacarpal bone, and also shortening of the middle phalanx of the middle finger. And you see, these are some of the manifestations. In the chest, you got the changes of marrow hyperplasia with expansion of the ribs and some trabeculations. Also, according to the literature, you can see that the colonic gas is replacing the site of the spleen, and this of course, this cannot be diagnosed from the plain film, but they said that it is due to autosplenectomy. And this is once more the changes of sickle cell disease with H-shaped vertebra. And also here you can see the sutures or the collapses of previous cholecystectomy, because you know that sickle cell disease is one of the predisposing factors for gallstones. Then, as I have mentioned before, that the red marrow is the initial marrow found at birth. Then by time you got yellow marrow, which contains fat. Then, in cases of sickle cell disease and other of the hematological disease I will mention, you got the marrow reconversion into red once again. Then remember that the red marrow will show intermediate signal in the T1 and also intermediate signal in the T2 weighted image. Then in this appearance, you see that the vertebrae contains red marrow, which is of intermediate signal in the T1 and also in the T2 weighted image. Additional findings include the multiple collapsed or H-shaped vertebrae, and you got an acute infarction in the vertebra L3. And this infarction is of low signal in the T1 and high signal in the T2 weighted image. Also, the vaso-occlusive disease may result in epiphyseal osteonecrosis, and this is one of the common sites for epiphyseal osteonecrosis, which is the head of the humerus, as I have explained before. Also, the most common site for epiphyseal osteonecrosis is the femoral head, followed by the humeral head, and we have described the manifestations of femoral head osteonecrosis. Another example, bilateral, more severe on the right side with flattening irregularity and disturbed joint space. And this is another example where you see the affection of the humeral head and also affection of the femoral head in a patient with sickle cell disease. The changes in the hip are more severe than the changes on the shoulder. Thank you very much. Alhamdulillah.